Hey crew, welcome to Nursing 201. We're going to talk about Chapter 14, Depressive Disorders today. So, depressive disorders. I'm sure you guys are very familiar with depression. It's a very common illness. In fact, it is one of the leading causes of disability in the United States. It's actually overtaken things like back pain. So this is a very important chapter, as you guys are definitely going to run into patients who struggle with depression on your floors, regardless of where you decide to work. So we're going to talk about symptoms of different types of depressive disorders, including disruptive mood dysregulation disorder, or DMDD. We're going to talk about persistent depressive disorder, dysthymia. We're also going to talk about premenstrual dysphoric disorder, as well as talk about, obviously in depth, major depressive disorder, which is the most common form of depression that is diagnosed. So it's important to note that all depressive disorders share symptoms: sadness, emptiness, irritability, somatic, which is like body pains or body concerns, and impairment of thinking. But the most important thing to remember is these are diagnosed when they become a problem in regards to a person's function. To be diagnosed with a depressive disorder, you have to meet the DSM-5 criteria, and there has to be significant impact to a person's daily life in order to get this as a diagnosis. So, depressive disorders classified. Major depressive disorder. That is, again, the one we're going to be predominantly focusing on. But also, disruptive mood dysregulation disorder. Now, this is a diagnosis commonly given to children, and this is really supposed to be the precursor to something like a bipolar disorder in kids. It's to establish that there's definitely dysregulation. There's sadness, there's irritability, there are all the traits that we would normally see in a depressed patient, or possibly a bipolar patient, depending on what was going on with them. But this is really something that we should be seeing children diagnosed with without jumping straight to a bipolar disorder. Persistent depressive disorder, previously called dysthymia, you guys may know as being called the blues. You'll hear people say, oh, they've had the blues. They've had them for a long time. And we'll talk about dysthymia a little bit more. Premenstrual dysphoric disorder, or PMDD, is a far more understood disorder these days, and we'll discuss that as well as substance or medication-induced depressive disorders and depressive disorders due to another medical condition, and there can be many. So, persistent depressive disorder, the blues, formerly known as dysthymia. When DSM-4 changed to DSM-5, that is when they got rid of the phrase dysthymic or dysthymia. We still use the phrase dysthymic to describe someone who has a sad mood or affect. So that is a phrase that we're still using, but it's not as common as it used to be. In order to get this diagnosis, a patient has to have low-level depressive thoughts through most of each day for the majority of days. It has to last at least 2 years. Now, you guys are thinking, wow, that's a really long period of time. 2 years in adults, a year in children. And, with that in mind, it can be hard to pinpoint and hard to target when somebody has this as a diagnosis. Because if they have had periods in their life where maybe they felt a little better. Maybe it was situational. Maybe they got married, or maybe something positive happened, a new job, a new home. People who have positive days may be misrepresented, I guess is the word I'm searching for, in how severe and how persistent their depression actually is. They must also have 2 or more of the following: a decreased appetite or overeating. So if you imagine, if you will, there are some people that present with depression and they'll tell you that they don't have much of an appetite. They might have weight loss or overeating. So imagine that person sitting down and eating an entire pint of Haagen-Dazs or a half gallon of ice cream in a sitting, right? Insomnia or hypersomnia. So it's not always the person who is wide awake with their brain spinning. It can be the person that just doesn't want to get out of bed. Low energy, poor self-esteem, difficulty thinking or focusing, feelings of hopelessness. And hopelessness and helplessness are very important key attributes. So we're going to talk about that a little bit more when we talk about risk for suicide. Premenstrual dysphoric disorder is a symptom cluster of depression in women that last in the week prior to onset of a woman's menses. They may have mood swings, irritability, depression, anxiety. They may feel overwhelmed. They have difficulty concentrating or focusing on tasks. Now, previously, it was always kind of thrown around, oh, she's just premenstrual. But now we're understanding the effects that estrogen and progesterone actually have on premenstrual dysphoric disorder. The symptoms decrease significantly or even disappear once the woman has the onset of menstruation. So it's understood a little bit better, and with that in mind, we can start to combat it a little bit better. Other depressive disorders may include substance-induced depressive disorder. The person, it's very important to state, with this diagnosis, a person does not experience depressive symptoms with if they're not on drugs or alcohol at the time. Okay? So what that means is if the person is not actively using, and if you think about a lot of drugs, they're CNS depressants, right? So benzodiazepines, opiates, people who are abusing alcohol, these are all CNS depressants, barbiturates. They are at risk for a substance-induced depressive disorder. Kind of like those people that drunk text in the middle of the night and they send messages about, oh, I might as well not be alive if she won't come back to me, or I can't deal with my life right now. And then when they sober up, they're like, no, I feel fine. I don't know why I sent that. Do you know how many people come to the ER because they've made a statement like that? And I can tell you the number is very large. Major depressive disorder. So 5 or more of the following in a 2-week period: weight loss, appetite changes, sleep disturbance, fatigue, feelings of worthlessness or guilt, loss of ability to concentrate or focus, recurrent thoughts of death. Plus at least one symptom that is either the depressed mood or anhedonia, which we talked about when we covered medications. And anhedonia becomes a very important player because remember, when we start giving antidepressants, that lifting of anhedonia becomes a time period when these patients are particularly at risk. So major depressive disorder, a persistent diagnosis is from 2 weeks to 6 months. Somebody with major depressive disorder chronic, they've had it for more than 2 years. Recurrent episodes are common. People with major depressive disorder may go through periods of their life where they're fairly asymptomatic. They may not require medication. And these are people that have usually, if they're in remission, usually they've undergone not only medication, but also significant therapy, CBT, DBT, different ways of coping and dealing with their stressors. It's important to note that the episodes are not attributed to physiological effects. There are a lot of different things, such as hormone shifts, tumors, issues with the thyroid. Hypothyroid is a key issue that we have to look for when a patient comes in complaining of depression, especially if it's a new onset. We need to do thyroid levels because thyroid will often cause depressive symptoms. It's also important to note that there needs to be an absence of a manic or hypomanic state. Now, when you guys complete your web quests for bipolar disorder, you're going to get a better understanding of what we mean by manic versus hypomanic, and also a better understanding of why, especially hypomania, is not always easy to target. We don't always know. We can ask patients questions, and it's very careful. We have to be very careful in how we phrase it, and also getting a detailed core history of family members and their behaviors in order to get an actual diagnosis of bipolar disorder. So hopefully an MDD patient started on an antidepressant will get symptom relief, but won't get the issue with activation syndrome that we discussed when we covered chapter 3. So again, it is really important to remember that it is the leading cause of disability in the United States. With that in mind, treatment is more important than ever. It is one of the targets as far as trying to have an argument for creating more mental health services in communities. As many of you guys learned when we covered what's available in certain areas, there are some certain areas that are thick with services, and then there are other areas that service is extremely lacking. So it's important to note that availability of services is another issue with epidemiology in the United States for depression. The other thing of note is how it presents in children and adolescents and older adults may be different than the way it presents in an adult, a standard adult. Children, babies even, can have indication of depression. Loss of things that they're interested in, not wanting to play with friends. Oftentimes it may manifest as irritability and crying. It may manifest as somnolence. So it's important to remember that children and adolescents oftentimes it does show as withdrawal, irritability, not wanting to be with peers, loss of interest. They get anhedonia just like adults do. Maybe before they were addicted to Fortnite and had to be on 3 hours a night with their friends, and then all of a sudden they're saying they're not really interested and they can't really be bothered, and they might be sitting alone in their room. In older adults, the elderly population, one of the biggest problems is the fact that it's often underdiagnosed. It is never normal to be depressed. It is never normal to have anxiety. A lot of people will say, oh, well, they're just old. Of course they're depressed, but it is never normal, okay? Comorbidity with depression. I'm sure that you guys can think of a bunch of them. I know the first thing that comes to mind for me is anxiety. And it's often argued, does the anxiety cause the depression or does the depression cause the anxiety? Other comorbidities may include issues with perceptions of their own body. It may include issues related to chronic pain and somatic complaints. They talk about depression and fibromyalgia, and that's another one. What came first? Are they depressed because they have fibromyalgia, or do they have fibromyalgia because they're depressed? And they've not been able to really clearly pick that apart yet. From an etiological standpoint, there's that diathesis stress model. I know that's going to be a shocker to you guys. Genetic and biochemical, which is basically you have the genetic predisposition, you are prone to having these issues, and then you have a stressor or trauma. And that stress or trauma may be different for different people. You've got some people that can take a fair amount before they give in to that stress or trauma. And then you've got other people, especially if there's a high genetic predisposition, it may not take as much to have a patient end up with full-blown depression. Alterations in hormonal regulation can be a biological factor. Again, we talked about PMDD. So we're talking about estrogen levels. We're talking about progesterone levels. Those types of things may affect depression, as well as issues in, like we had said, thyroid and thyroid function. Ultrasensitive TSH is usually the starting point. They may look at T3, free T4, and other possibilities for issues with the thyroid. And then finally, again, inflammatory process, fibromyalgia. It's questionable whether the fibromyalgia itself causes the depression or the depression causes it. And there are other chronic pain syndromes as well. At this point, it's important to know that those two do definitely go hand in hand when we're talking about etiology and epidemiology. So what are we going to do? How are we going to take care care of people who are diagnosed with depression. Now, if you know you're going to see it on your units, regardless of where you work, even if you're working in a doctor's office, this is a big part of what we're screening for these days. So we need to know how to assess behaviors in patients with depression. We need to look at their affect, their thought processes, their feelings, physical behavior, communication. And I want you to add mood to that, right? Because mood and affect are really predominant parts of the MSE. They're predominant parts of what we're looking at when we're assessing whether or not a patient has depression and whether or not they're at risk. And then we're going to talk about nursing diagnoses for patients with depression and talk about the importance of realistic and achievable outcome criteria. So the nursing assessment. Fortunately, last week, you guys already did your first MSE, and you were introduced to a patient, an elderly patient struggling with depression. The MSE is a primary assessment tool that we use for these patients, but it's important to note that before we do any of that, it is important that we get a good medical workup, right? So the first key in the assessment is really going to be to make sure that there is an underlying medical reason for these patients to feel the way that they feel. You think of fatigue, you think of appetite loss, irritability. If you're overtired, sometimes that causes irritability. There are things like in adolescence, maybe they're more irritable, they're more tired, they've had a change in appetite. They might have Epstein-Barr. They might be struggling with mono. So it's important to look at medically, is this person sound? Then if they're sound, we move on to the assessment tools like the MSE. After the MSE is completed, we are going to complete the assessment of suicide potential. Remember, the gold standard for this is going to be the Columbia Suicide Scale. Now, whether you know it or not, you've had the Columbia or at least a partial Columbia completed on you, more than likely, if you've ever had a doctor's appointment. When you're at the doctor's, they will ask you, have you had any feelings of depression? Have you had any feelings of self-harm? Do you feel safe at home? Or at least they're supposed to be asking you these things. The feelings of self-harm are basically, it's the short version of the Columbia Suicide Scale. If you were having depressive symptoms, they may have an expanded suicide scale, asking you whether or not you've had any thoughts or have done anything to start to plan for or attempt self-harm. From there, if you do have suicidal thoughts, if you have had, say, making plans to harm self, that's when the extended, like the full Columbia Suicide Rating Scale would come out. So that is one of the ways that we assess suicide potential. And then we also use the Beck scale to look at depression. So key assessment findings, not surprisingly, depressed mood and anhedonia, inertia. Remember when you've got an at the beginning of it, it's lack of, so anhedonia, lack of hedonism or lack of drive and desire, inertia, lack of energy, anxiety, psychomotor agitation or retardation, vegetative signs. And vegetative signs would be things like laying in bed, not engaging, not getting out of bed to attend one's ADLs, just kind of laying on the couch under a blanket and staring at the TV, being essentially nonverbal. Those would all be vegetative signs. Think of someone who is almost like comatose, just kind of laying there staring. That would be vegetative. And then the comorbidity of chronic pain has to be assessed. So anhedonia. I'm not sure if I'm depressed because I have no motivation, or I have no motivation because I'm depressed. So anhedonia, very important phrase for us in assessment in psychiatric illness. Nursing process. So what are we going to assess? As you guys saw with the MSE, we're going to assess the mood. The mood is objective. The mood is subjective. I apologize. The mood is subjective. They are going to tell you what their mood is. You're going to ask a patient, how's your mood, or what has your mood been like? The affect is objective. It's what they show you. It's what their face is saying, their eye contact and posture are saying. What are their feelings about what's going on? Are their thought processes, are they clear? Are they able to tell you what day it is? Are they able to tell you who they are and where they are? So think of like alert and oriented times 4. You want a patient to be able to engage in those thought processes. Are they able to focus and concentrate? Are they able to pay attention? Physical behavior. What is their physical behavior showing you? Are they pacing? Do they seem irritable? Are they tearful? Are they making poor eye contact? How is their communication? A lot of times when people are depressed, they'll have depressed communication, meaning it's usually less fluent. It's more blunted. So they'll answer you with yes or no answers, especially if you give them closed-ended questions. Very kind of short to the point. They don't really want to engage. Now, it's important to look at religious beliefs and spirituality as well, because this can be not only a protective factor, but it can also be a risk factor. If that person is devout in their religion and they perceive themselves as having done something wrong, that can actually potentiate their risk. However, take somebody who is, I tend to pick on Catholic because I was raised Catholic and I'm more familiar with it. Someone who is Catholic, then suicide is a mortal sin. So it becomes a protective factor in their depression, that even if they are having thoughts of death, they may not act on them because they have a fear that they will end up, that they'll end up in hell, that it's a damnation type thing. So again, religion can be a positive thing or a negative thing based on the patient's presenting history. Age considerations, again, talk to them at a developmentally appropriate level. You're not going to talk to a 5-year-old the same way you talk to a 15-year-old. 5-year-olds are not, they're concrete. They don't have the ability to abstract when you ask them questions. So if you ask them leading questions, they may tell you what they think you want to hear, or they may parrot things back to you that they don't understand. So if you say to a 5-year-old, "Are you having thoughts of suicide?" they may not understand what the word is and just blindly agree with you and say, "Yup," versus, "Tell me what happened when you were sad," or "Tell me why you're sad." So be careful in your phrasing. Older adults, when we're dealing with the elderly population, keep in mind that normal cognitive changes include slowing of communication and a delay in thought process. Give them time to answer. With the elderly population, if they feel rushed or hurried, they may shut down. So it's very important to give them a supportive type of environment, one where you are sitting at their level and not looming over them, one where you ask a question and give them time to answer. It's also important to note whether or not they've got, say, hearing issues. If they've got hearing issues, they may also just agree with you because they can't really clearly hear what you're saying, and that may be embarrassing to them. So always assess, maybe they hear better on the left than the right. If they hear better on the left, you're going to sit on their left-hand side. Exactly. It's important, again, as I always say, before you work with anybody who's depressed or anxious or anybody that may be struggling, it's important to check yourself at the door. We talked about the risk for countertransference, and if you are struggling with depression yourself and if you don't check yourself at that door, it can make working with those patients particularly difficult. Also, if there's a family or personal history of depression, our risk for countertransference is significantly higher. Now, that's not saying that you can't struggle with depression or anxiety and not do very well working with those patients, but you need to be mindful of your own behaviors and what's going on with you in order to give the best care. So, nursing diagnoses. Risk for suicide, because safety is always the highest priority, period. period. Because is ineffective coping important, or social isolation, or nutritional deficit, or altered sleep patterns important? Of course it is. But it is all a moot point if you're dead. If the patient slips through the cracks of safety and the patient commits suicide, the rest of it doesn't matter. So risk for suicide is always the highest priority. It's important to note that if a patient states that they are feeling hopeless or helpless, that this is a huge indicator for risk of suicidal thought and suicide attempt. It is one of the primary indicators. So if you have a patient on a med-surg floor who tells you, I just got diagnosed with XYZ and I'm really feeling hopeless and helpless right now, pay attention. Make sure that a Columbia scale is done on that patient. Make sure that the provider is made aware. That patient may require something like a psych evaluation on the floor. They may require extra support. So it is extremely important to keep that in mind. Outcomes need to be realistic and achievable. You have to work with the patient, because setting up outcomes for a patient that they don't or can't engage in is pointless. They're not going to want to engage. So the patient really needs to be part of the dialogue when you're setting up your nursing care plans. The recovery model focuses on patient strengths. Nobody wants to focus on the stuff that they're bad at. So the point is, focus on things that are realistic and achievable, that the patient wants to work towards, that they state that they're good at. If they state that they're really good at talking to people, or they state that they're good at helping others, things that you can do with them in regards to the nursing process may be really more positive for the patient. They may be more beneficial for the patient if they're based on their strengths. That treatment goal needs to be mutually developed. It needs to be based on the patient's personal needs and values. And that may differ from your own, and you may disagree with them, but honestly, it's got to come from the patient. When you're setting up planning, again, try to set up planning in such a way that it's going to be geared towards where they are in depression. If you've got a patient who's so depressed they can't get out of bed, they aren't showering, they aren't feeding themselves, maybe you set a goal of they will shower twice a week. Then maybe it's 3 or 4 times a week. Then it might move to shower daily. We need to scaffold and build upon small goals and small victories, giving them praise for that along the way. It has to be based on their particular symptoms, and it has to be based on the patient's personal goals. Maybe their goal is to feel better and get back to work, right? So you have to start with, how would you present yourself to go to work? You need to be clean. Your clothes need to be taken care of. So helping them function independently and do things like wash their clothes would be big steps towards those goals. Implementation has to be done in 3 phases. It's important to know that the acute phase of the illness is 6 to 12 weeks, right? But really the acute phase is the first 12 weeks completely, because remember, in the first 4 weeks, especially the first 4 weeks, we have the potential for the lifting of anhedonia. That is going to be a time frame when they may require a lot of nursing support based on what's going on with them. 6 to 12 weeks, they're still considered in the acute phase. It's important to know that during that time, they may be engaging with their psychiatrist more, engaging with their therapist more. They may be seeing them weekly. Continuation phase from 4 to 9 months, they're a little bit more stable. They're feeling better. During that time frame, they may get backed down to seeing their therapist every 2 weeks. Maybe they're seeing their psychiatrist monthly instead of a weekly or every 2 weeks. And then finally, the maintenance phase. A lot of times it's a check-in every 6 months to a year with the psychiatrist to continue with the medications unless there's been a change or a problem. And oftentimes therapy, maybe once a month, just enough to kind of touch base and make sure that they're doing well. Counseling and communication health promotion and health teaching, promoting self-care, and teamwork and safety. And these are all important because, again, our goal is never to keep a patient in the hospital. We need to set them up in such a way that they're actively engaging, they're taking care of their basic needs, promoting their own self-care activities. We need to teach them skills so that when they get back out into the community, they can actually function at their highest potential level, right? So teaching things like coping skills and role modeling how we deal with stress, how we deal with negative emotion can be a big part of health promotion. And then teamwork and safety, we all have to be on the same page. We have to make sure that if one person says a patient can't have an item that's contraband, that the other staff all agrees, everybody's on the same page, and that patient is being well taken care of with teamwork and safety in mind. We don't want to be sending mixed messages because that can be very upsetting and frustrating to a patient. Nursing process. So we need to look at the evaluation of the patient themselves. We want to look at their suicidal ideation, if any. Now, it's important to note that not everybody who is depressed becomes actively suicidal. Remember that when they talked about the two big symptoms, it was either depressed mood or anhedonia. It may or may not be in combination with thoughts of suicide. Generally speaking, a patient who is not suicidal may not be taken care of on the unit. So these may be patients that you're taking care of on a medical unit, in an ICU, on obstetrics, right? We need to look at their intake. Are they eating? Their sleep pattern. Are they sleeping? If so, is it enough or is it too much? What do their ADLs look like? How do they rate their self-esteem? And are they interacting with others appropriately? These are all important attributes that we look at every time we evaluate a patient with depression. So let's look at some of the meds. We've covered them briefly in chapter 3, but we're going to kind of look at them again, and we're going to talk about use of ECT for depressive disorders and other treatments that are being used. So how do we choose the pharmacological agents? How do we choose an antidepressant for a patient? Well, the symptom profile is a big part of it. We talked briefly about the fact that there may be a comorbidity with a pain syndrome like fibromyalgia. If they're having chronic pain issues, then we're going to look at an SNRI, something like duloxetine or Cymbalta. If the patient struggles with anxiety as well as depression, we may look at medications such as paroxetine, sertraline, citalopram. Those are all SSRIs. We may look at venlafaxine, which is an SNRI. Those medications are going to help with anxiety as well as depression. They look at the side effect profile. Obviously, if sexual dysfunction is a big deal to that patient, if weight gain is a major concern, they're going to try to pick medications that have the least of those issues. If a patient complains that they're tired all the time, sometimes they'll pick a medication that's known to create kind of an increased anxiety state. Anxiety maybe isn't the best word, but it gives them an increased level of energy. For instance, a lot of people complain that sertraline will keep them up. It makes them very awake, in which case it would be really good to give that to somebody in the morning if they're having complaints of being sleepy. Ease of administration is always an important thing because the easier we make medications for people to remember, the better they do. If it's a situation where you've got somebody who isn't going to take medications BID or TID, if we can find a medication that works for them that you take once a day, it's going to be better. If we can find a medication that maybe they're pretty alert in the morning, but they fall asleep on the couch and they always forget to take their meds at night, you want something like a sertraline that is normally given in the morning. If you've got somebody who tells you they're not a morning person, they hate to get out of bed, they're not consistent with what time they wake up, then maybe something taking an hour's sleep is a better choice. Here's an important one. History of past response or past response of a first-degree relative. It is important to note that if a family member has been on an antidepressant with good effect, and especially if they've had minimal side effects, because there's a shared genetic response, that medication should be considered for the patient. Safety and medical considerations, again, we talked about tricyclic antidepressants and how they're cardiotoxic. If you have a patient who has issues with medication or has an issue with cardiac symptoms, then you're definitely going to want to look at not doing a TCA, because a TCA has the potential to have cardiac issues. SSRIs, we've discussed before, they are the first line therapy. They are the gold standard of care for treatment of depression. There is a rare risk of serotonin syndrome. The same with SNRIs. Anytime we're messing with serotonin, norepinephrine reuptake inhibitors, SNRIs, may be tolerated better, but they also run the risk of serotonin syndrome. And if they're taken in a dose that's too high, it definitely, maybe if someone doubles up on their medication or there's been an issue like that, they may have a risk for serotonin syndrome. SSRIs of interest, venlafaxine comes two different ways. It comes as a short-acting and it comes as a long-acting. And what they found is the short-acting venlafaxine over time oftentimes just spontaneously stops working for patients. So they often use the venlafaxine XR with better effect. Tricyclic antidepressants, our big deal was don't give more than a 7-day supply, because remember, an overdose on TCAs, and amitriptyline is the only TCA that we're going to be covering, but overdose on TCAs can be cardiotoxic. It can cause fatal arrhythmias and death. And then, of course, monoamine oxidase inhibitors. They do occasionally still use them for unconventional depression or depression that's just not responding to SSRIs or SNRIs. They need to be used with caution. And of course, we need to think about tyramine foods and the effect that tyramine has on hypertensive crisis. So other treatments for depression. ECT, electroconvulsive therapy, we've talked about on and off. This is use of shock therapy, as they call it, where electricity is sent into the brain. It basically functions like rebooting a computer. It may be unilateral or bilateral. It is still commonly used. Remember that with ECT, we need to make sure that the patient has not been on any anti-seizure medications or benzodiazepines prior to having the treatment. Transcranial magnetic stimulation is basically MRI level magnets that are used. It basically looks like really fancy headgear, and they shoot magnetic waves through the brain. Pinnacle, which is, I believe, in Clifton Park, is one of the local area doctors or agencies that are doing TMS. TMS, most commonly, there is complaint of headache afterwards. Vagal nerve stimulation and deep brain stimulation, they try not to use whenever possible, because obviously anytime we're implanting electrodes, that becomes very invasive. Light therapy. This is very interesting, very common for seasonal affective disorder, and basically lights in certain degrees of lumens are used to increase the absorption of vitamin D. Anybody who is, well, basically where we live, anybody in the northern hemisphere, the upper parts of the northern hemisphere are much, much higher risk for lack of vitamin D, for seasonal affective disorder, so light therapy can be very helpful. And then finally, St. John's wort, which again, if a patient is taking this, we need to know before an antidepressant is prescribed. They may not see this as being medication per se because it's herbal, but it can cause a serotonin syndrome if too much of it is taken, or if it's given in tandem with other antidepressant medications. And then finally, exercise. There is strong evidence that exercise, especially high degrees of aerobic exercise like running, you think of endorphins and runner's high, these are all extremely positive treatments for depression. Patients who engage in exercise in combination with therapy and meds generally do very, very well. So again, ECT. Psychotic illnesses may be another indication. ECT and the primary treatment of severe malnutrition, exhaustion, if they've been depressed for a very long time, if the medications aren't working, this oftentimes becomes a last form of therapy. It may be safer than meds depending on whether or not they've got cardiac conditions. Delusional depression, so a depression that has psychotic features, this may be helpful. Maybe they've failed other medication trials. And they talk about schizophrenia with catatonia, but for just one moment, I want you to think about this. We haven't covered schizophrenia yet, but schizophrenia with catatonia or catatonic symptoms. So think of somebody who just basically lays in bed, doesn't engage, doesn't feed themselves, doesn't change themselves, and requires extreme amounts of care. They have very low cognitive functioning, like they're in there, they're trapped in there. But these guys are not exactly good at making executive decisions. Would it be ethical to give that person ECT if they didn't know what they were signing up for? I just want you to think about that. TMS, again, they say it's non-invasive. They usually get headaches as a side effect, occasional lightheadedness. But unlike ECT, they don't get neurological deficits or memory problems. It is important to note, though, that the memory problems that can occur with ECT generally go away over time. Occasionally they'll have seizures, but they're very rare, and usually they just complain of feeling like a tingly scalp. Vagal nerve stimulation, originally used to treat epilepsy. They say that it boosts the levels of neurotransmitters. I would like to see the PET scans on this. I have not worked with a patient who has had depression, has had VNS, but it also comes, again, with more side effects because of the fact that it's actually invasive. Neck pain, cough, paresthesias, dyspnea, those do tend to go down with time, but that can be very uncomfortable and anxiety-provoking for patients who already have depression. DBS, more invasive than VNS because the electrodes are going directly into the brain, stimulates regions that they consider to be underactive. And again, this is the most invasive of the different types of therapies. Light therapy, again, really well tolerated, positive for many people that live in the Northern Hemisphere, may cause some headache or jitteriness. Really, the most important thing to note from light therapy is to make sure that the patient isn't doing it right before they go to bed. St. John's wort, this is something that can cause serotonin syndrome if it's taken in large quantities, and it is useful in mild to moderate depression for some patients. So what do our APRNs do? What do our nurse practitioners, psychiatric, what is their job? Now notice, I love this word, therapy, okay? It is the nurse practitioner's job to therapize, I like to make up words as I go along, the patients. Therapy is outside the scope of practice for a regular RN out on the floor, okay? We do not engage in therapy. So if you see the word therapy, cognitive behavioral therapy, interpersonal therapy, time-limited focus therapy, group therapy, behavior therapy, dialectical behavioral therapy, we can work with patients on their skills that they've been taught, but we do not do the therapy itself. That is very important to note, okay? The other thing is, nurse practitioners, psychiatric, or psych NPs are going to be the ones that are also prescribing. They have prescriptive abilities. They're able to prescribe these medications. So a patient with major depression walks and moves slowly. Which term should the nurse use to document this finding? Now remember, slowly. Doesn't say they're not moving. Psychomotor retardation would be the right phrase. So they're still moving around. They're walking, they're moving, they're getting up out of a chair, they're sitting down, but they're doing it slowly. Psychomotor agitation may present as grimacing, pacing, maybe they're flexing their hands. Their movements are a little quicker and a little more agitated. Vegetative sign, again, is like those comatose signs where they're laying on the couch wrapped in a blanket, not blinking, not talking. That would be more vegetative sign. And then, of course, anhedonia is a loss in interest or desire to do things that they previously enjoyed doing. Which assessment finding in a patient with major depression represents a vegetative sign? The answer is B, hypersomnia. Because remember, restlessness, that would probably be a psychomotor agitation. Feelings of guilt is not a vegetative sign. Frequent crying is not a vegetative sign, but hypersomnia, or the desire to sleep all of the time. Maybe they're sleeping, 22 out of 24 hours out of the day. They get up, they wander to the bathroom, they go back to bed. That would be vegetative sign. All right, and that is the end of the chapter.